Hello and welcome. I'm Claudia Rizzini. I am the Executive Director of the Fellowship Program at the Harvard Radcliffe Institute. It is my pleasure to introduce Lisa Iezzoni. Lisa has said that her goal in becoming a doctor was to help people. Although not a practicing doctor, her progress on that goal has led her to 40 years of unique and vital research in healthcare disparity in cancer care, in primary care, and in reproductive health for people with disability. Lisa's work is remarkable in many ways. Those who know her speak highly of her vibrant and humanizing writing style, her rigorous scholarship, and her fearless willingness to expand her horizons. Lisa has had multiple sclerosis for 46 years. She has used her talents consistently to highlight barriers to equitable healthcare for disabled people, often overlooked in medical practice and research. She has described herself and her scooter wheelchair as a rolling focus group and spoken explicitly against expectations of silence around disabling conditions. Lisa's work this year makes use of a series of interviews she conducted with staff, with patients, and associates at the Community Medical Alliance. She hopes that this program's notable quality of care and respect towards patients can be duplicated in other medical initiatives. On a summer afternoon, you can come across Lisa on her way down from her office at Massachusetts General Hospital to the Boston Harbor to watch the waters, boats, and birds. So now it is my great pleasure to introduce Sally Starling Seaver Fellow, Professor Lisa Iezzoni.
Thank you so much, Claudia, for that really wonderful introduction. Thank you to the Radcliffe Harvard Fellowship for giving me this opportunity, and thank you for all of you for coming out to hear me this rainy afternoon. Okay, only 4% of Americans would want to enter a nursing home if they become chronically ill or disabled. So given that so many people don't want to enter a nursing home, want to stay in their homes and communities, why is it so hard to make that happen? I'm sure that some of you have dealt with this already in your lives, with a parent, another relative, or a friend, and it seems like it becomes almost a second job trying to make this happen. So the late Karen Buller Wilkerson, a historian of long-term care in the United States and professor of nursing at University of Pennsylvania, viewed paying for home-based services and supports as the most intractable of many intractable health policy problems confronting America. And it's been here since the nation's founding. For more than 200 years, no agreement has been reached concerning the proper balance between governmental resources and the private resources of family, friends, and insurance for providing in-home supports to people with chronic disease or disability. So yes, Claudia, I'm going to be talking about Community Medical Alliance in my fellowship and hoping to draw lessons from that that can inform what's happening right now, still trying to figure this out. Community Medical Alliance, briefly, was a Massachusetts Medicaid demonstration program from 1992 to 1996. It provided in-home care for people with severe disability or late-stage AIDS, and it started before the 1994 arrival of the highly active antiretroviral drugs for AIDS. It served people in the greater Boston area and Springfield, and even though it seems kind of like, yeah, everybody does this, back at the time, interdisciplinary teams were actually kind of novel, and it involved primary care physicians, nurse practitioners, and physician assistants going into people's homes. It also used capitated payment. In other words, Massachusetts Medicaid gave CMA a particular amount of money for each member per month, and then CMA decided how to distribute it. And again, I'm hoping that the CMA experiences can teach us today. So my talk topics are briefly to talk a little bit about the history, why we still haven't figured this out, talk about the premium on living at home, give a brief overview of home-based supports, and then finally talk a little bit more about the CMA project and the fellowship. Okay, brief history. All right, so European settlers figured out that when they crossed the Atlantic, they got to pretty rugged territory, and that only kind of really fit people were going to be able to literally survive in these environments. And so ships to North America from Europe generally rejected passengers without the bodily or mental stamina to endure these rough conditions. A 1701 Massachusetts law required ship captains to return at their own expense, quote, lame, impotent, or infirm persons incapable of maintaining themselves, close quote. Colonies could deport people with physical or mental impairments. Newcomers were required to prove that they would not become a financial burden to the society. And in fact, families from the very start were expected to provide subsistence and needed care for other family members who needed it. The situation was stark for Africans who were abducted to become slaves in the colonies. Preparing them to ship overseas, the slave traders in Africa systematically winnowed out those seen as less fit and therefore without economic value, often killing older people, many children, and people with disabilities. People who survived the Middle Passage and arrived healthy were frequently disabled by hard labor, brutal physical punishments, mental anguish. They became, again, without value to slave traders and were left adrift to try to subsist for themselves as they could where they were. Now, not every family or every person has a family that can care for them, and so almshouses became a public way of providing subsistence and shelter for people without family members who could provide this care. And in fact, the first almshouse was established in Boston in the colonies in 1662. This picture shows the almshouse that was established on Leverett Street in the West End of Boston in 1828. And at that point, the West End was considered rural. Trust me, right now, it's covered with high-rise apartment buildings and condos. By 1860, there were actually 219 almshouses in Massachusetts. Many European immigrants who came over had to spend time in almshouses, and this was a pretty miserable thing to do because infectious diseases caused a high mortality rate, about a 20% mortality rate in these facilities. Enslaved people had even fewer options. Families were often separated, eliminating that support structure that Europeans were expected to have. Slave owners would sometimes, quote unquote, free old, sick, or disabled enslaved people, leaving them to fend for themselves, literally in the woods or territory surrounding the plantations. The iconic Frederick Douglass wrote and spoke frequently about his cousin Henny, who had been debilitated by childhood burns and was unable to labor the way that her slave owner expected her to, being, quote, set adrift to take care of herself, a helpless child to starve and die. In the early 1800s, a variety of different types of disabled people, people who are blind, people who are deaf, people with physical disabilities, people with intellectual and developmental disabilities began to be institutionalized because of progressive thinking and science, who thought that, hey, in institutions we can rehabilitate, we can reform these disabled people. And so, for example, the New England Asylum for the Blind was established in Boston in 1829 when its inhabitants outgrew their initial facility. A board member, Thomas Perkins, donated his Pearl Street house that you can see in the picture on this slide, and it became the Perkins Institute for the Blind. And then it became the Perkins School for the Blind, changing institute for school, when they moved to their Watertown campus, just up the street from where we are now, in 1913. And Helen Keller and her teacher, Anne Sullivan, are the most famous residences of the Perkins School for the Blind. They lived there from 1888 to 1893. However, often the institutions lost their missions. And this is a picture of, again, I'm using examples locally because I just thought that was kind of interesting to do, from Waltham, which again is just kind of up the street, of something called the Massachusetts School for Idiotic Children. When it was founded in 1877, it later became the Fernald State School. These institutions often just warehouse their inhabitants. The eugenics movement and social Darwinism perpetuated this institutionalization into the early 20th century. And to this day, there's still a legacy of distrust among many disabled people that comes from this history. All right, so this is a picture of arguably the most famous disabled person of the 20th century. But of course, the vast majority of people didn't know that he couldn't walk after contracting polio at age 39. Of course, this is Franklin Delano Roosevelt, and this is one of only potentially two remaining photographs of him in his wheelchair. The press corps really protected him from being exposed, and so a lot of the public just didn't know he couldn't walk. His signature act to kind of get our country through the Depression was the 1935 Social Security Act, but it had interesting consequences. In it, the means-tested old age assistance program applied only to people not living in institutions. So it did not apply to all the people in almshouses. And this actually led to the original development of the private nursing home industry. And subsequent amendments to the Social Security Act further solidified the nursing home industry, such as the 1950 Social Security Act amendments, in which medical payments were to be paid directly to nursing homes and not beneficiaries, thus again strengthening nursing homes. This slide is of President Lyndon Baines Johnson signing into law on July 30th of 1965, Medicare, which is the federal health insurance program for older people, and Medicaid, which is a joint federal and state program for poor people and people on quote-unquote welfare, in Independence, Missouri, at the side of President Harry S. Truman, who had fought for health insurance for many, many years. It's interesting that when these programs were enacted, long-term care did not end up in Medicare, the entitlement program for older people. It was put into the welfare program. And so long-term care is part of Medicaid. When Medicaid was enacted, it was required to support nursing homes for everybody 21 and older, but it was only in 1981 that Medicaid waiver programs were put into effect that allowed states to support community-based services. And states now across the country make individual state decisions about how much of their long-term care dollars they want to pay for home-based services versus institutional services like nursing homes. And trust me, states vary dramatically in this across the country. Okay, dignity. So far, what I've been talking about is mostly what I'll call, and many have called since the early 1800s, the medical model of disability. The medical model locates disability within individual people as their problem, caused by disease, trauma, health conditions, the solution is a cure or medical treatment. People are expected to follow the recommendations of their healthcare professionals, to do what their doctor tells them to do, and then if they're not cured or treated, they need to accept and adjust to their loss and limitations. However, in America, this started to change in the mid-20th century. The first instigator of change was all the World War II veterans returning, sometimes with significant injuries, but wanting to get back to work as civilians. And so they needed accommodations to be able to work, and sometimes those accommodations applied not only to vets, but to other people. And then, of course, in the 1960s, we had the civil rights movement for racial and ethnic minorities, and this, of course, is the famous March on Washington that happened on August 28th of 1963, led by the Reverend Martin Luther King. Disabled people saw this and they thought, what about us? We also had public exposés of just dreadful conditions at some of the institutions, and the most notorious was probably the Willowbrook School that had been founded in Staten Island, New York, opened in 1947 for, quote, mentally and physically defective and feeble-minded people. Trust me, even though it was called a school, there was a little teaching that happened there. Robert F. Kennedy called it as bordering on a snake pit. And it was only when Geraldo Rivera, the news reporter, snuck a camera into the institution, was able to take these horrific pictures that I'm sparing you of the conditions inside, that the Willowbrook School finally ended up having to close. Deinstitutionalization was slow, but it happened. From 1971 to 1990, for example, the number of people institutionalized with developmental disability fell from 195,000 people to 88,000 people. Then we get to the disability rights movement and see what the people did with the stars on the Stars and Stripes. You see that little wheelchair logo there? Yes, you do. Okay, so here is a picture of the iconic person leading the independent living movement. This is Ed Roberts, and shown here in his iron lung. Ed Roberts contracted polio at age 14. He needed for the rest of his life to use an iron lung at night to breathe. His doctor told his mother to let him die, that he would be, quote unquote, a vegetable the rest of his life. But he was a good student in school. The high school initially refused to graduate him because he skipped gym and he skipped driver's ed. But his advisors advised him to go on, and he attended community college, where he also excelled, and his community college advisors advised him to go to university, and he wanted to attend the neighboring kind of university, the UC Berkeley. But when he approached them, they said, quote, "We've tried cripples, and it didn't work." So Roberts, of course, like any good enterprising person, went to the local media, told his story, and he matriculated at Berkeley in 1962. On the campus, he lived in Cole Hospital because dorm rooms could not accommodate his iron lung. And his brother, who was also a student at UC Berkeley, provided his daily living supports. And then there continued to be newspaper articles about him, like this one with this particular headline, "Helpless Cripple Attends UC Classes." Well, this attracted a lot of other helpless cripples from around the country to apply to UC Berkeley and get in. And guess what? There were a bunch of them. And they called themselves the Rolling Quads. Get that? Rolling in a wheelchair, quads, the quadrangle at UC Berkeley. They eventually founded what they called the Disabled Students Union. They realized, though, that not everybody could have a brother attending the same university who was provide supports, and so they needed to create a support structure. And so Ed Roberts led what eventually became the Center for Independent Living, founded on Telegraph Avenue in Berkeley in 1972. It was the first independent living center founded in the country, and this is a picture at the ILC with Ed Roberts sitting in the middle, the bearded figure, and his team of other folks at the ILC around him. Roberts won in 1984 a MacArthur Fellowship Award, a Genius Award, for his leadership of the disability independent living movement. So this independent living movement led to the social model of disability, where the notion is that disability is a problem of societies that fail to accommodate difference. The causes are stigmatizing attitudes or failure to build accessible environments, social barriers. The solutions are to change social thinking, make communities accessible, and it became a human rights issue. Also, a civil rights issue. A year after the ILC was founded in Berkeley, which happened in 1972, in 1973, the US Congress passed the Rehabilitation Act. And in the shades of time, nobody really quite knows exactly how this happened, but Section 504 was snuck into the Rehabilitation Act of 1973. Section 504 stated, "No otherwise qualified individual with a disability in the United States shall, solely by reason of his or her disability, be excluded from participation in, be denied the benefits of, or be subjected to discrimination under any program or activity receiving federal financial assistance, or under any program or activity conducted by any executive agency." Civil rights for people with disabilities for federal programs. Who knew? It also actually outlined in Title VII, Chapter 1, independent living philosophy, a philosophy of consumer control, peer support, self-help, self-determination, equal access, and individual and system advocacy in order to maximize the leadership, empowerment, independence, and productivity of individuals with disabilities, and the integration and full inclusion of individuals with disabilities into the mainstream of American society. Independent living principles, equal dignity. There was another one that we all know that is kind of very frequently cited by people with disability, and that's the dignity of risk principle. And that is that people with decision-making capacity have a right to make decisions about how they live their lives. If they don't want to go into institutions when they're told to do so, they don't have to. However, it did take a few more years for the full National Americans with Disabilities Act to pass. And of course, we had more protests. This is an 8-year-old girl named Jennifer Keelan Chaffina, who had cerebral palsy, who climbed up the 83 steps of the US Capitol building on March 12th of 1990. And trust me, I was going to Washington a lot at this time. It was hard to get into the Capitol grounds back then, even. It just wasn't accessible. But months later, and this is the button that was given to people attending the July 26th signing of the 1990 Americans with Disabilities Act, an act that would give civil rights to people with disabilities in all public and private programs that serve the public. And this is the day that George Herbert Walker Bush said was the proudest moment of his presidency. Okay, briefly, home-based supports. So the most important home-based support for people addresses basic activities of daily living, or ADLs. That is feeding, bathing, dressing, toileting, basic mobility. These fall under the rubric of personal assistance services, or PAS. Family members or friends provide about 75% of in-home ADL supports in the United States. But for those who don't have family members or friends who can provide that support, that ADL supports, they need to pay PAS workers. And these workers are primarily Black and brown women, many immigrants. They earn low wages, They get meager benefits. They work multiple jobs to make ends meet. They're at high risk for exploitation and occupational hazards and injuries. In 2018, I was fortunate to get funding from the Gordon and Betty Moore Foundation to explore the health policy implications of paid PAS. And I insisted on interviewing people, consumers and workers, to be able to tell their narratives, their personal stories that I wove into my book about this that came out in January this year. And trust me, our nation is on a cliff. We're on a precipice. We're about to have a really incredible crisis in terms of being able to provide home-based supports to this aging population who is going to want to continue living at home. However, there are complexities for people who need more than what a direct care worker can provide, who need professional supports in a home. And Nurse Practice Act and other regulations in states can pose barriers to this happening. So as I was doing my Gordon and Betty Moore Foundation project, I started thinking about, okay, what's my next project gonna be? We all do that. And I thought back to my very first disability project that I ever did, my When Walking Fails project. It was a mixed methods project that was funded by the Robert Wood Johnson Foundation. In it, I interviewed a whole bunch of different types of people, including 56 people with progressive mobility limitations and many of their family members in their homes, if possible. And I used their stories to explore the health policy implications of progressive mobility limitations. Now, at this time, health maintenance organizations, HMOs, were disseminating rapidly because, of course, it was another time when our country was looking at these escalating healthcare costs, and they were trying to figure out how to control them. And again, HMOs, where providers get a fixed pot of money per month for everybody, was just not popular, as suggested by this March 31st, 1996 cartoon, where when Humpty Dumpty falls off the wall, because he's in an HMO, he can't call a doctor. He has to call some of the king's horses and a few of the king's men. But I, in my interviews, was hearing from people who loved their HMO, including a woman who I'll call Brianna. I rolled over to Brianna's house in January, her apartment, in January of 1998 on a mild January day in the Fenway neighborhood where the snow had kind of melted. She was in her mid-40s, disabled by neurofibromatosis. Small tumors had formed on her spinal cord. In her home, she used a manual wheelchair. When she went out, she used a power chair. But she was active in her community. She volunteered at AIDS Action Office on nearby Massachusetts Avenue. She said to me, quote, "If I have any problems, I just call up my nurse practitioner, and she comes to my home to check on me." She described her primary care physician, her PCP, as visiting her apartment, drinking tea, talking about how Brianna's life was going. Quote, "She saw I had a single bed and I was falling out of my bed. I needed a bigger bed. So she got me a special bed." The PCP arranged for Brianna to get a new wheelchair and a portable phone, which at that time was a new invention, so that was kind of cool. Some doctors don't know how to, quote, cope with people that are in a wheelchair. You have some doctors that just brush you off, but the doctors I have are excellent. Brianna was describing Community Medical Alliance, an HMO. And so as I was thinking about it, I thought, this is an important story to tell. Can we learn from what happened in CMA? By this point, I'm a very embedded person within the Boston disability community. I know a lot of the people who are involved in CMA. I also know that they're beginning to die. The oral histories are dying with them. And so I decided, you know something? I need to start interviewing. I need to start talking to all these people. So in July of 2018, I started trying to find as many people as I could, just kind of in my own time, sometimes in evenings, weekends, to try to talk to them. I ended my interviews just as the pandemic was really taking hold here in Boston in February 2020. I used snowball sampling. In other words, every time I interviewed a person, I asked, who else should I interview? I gathered available records. The interviews were transcribed from digital recordings, and there they are, lined up on one of the bookshelves to the left of my desk in my home. I interviewed physicians, I interviewed nurse practitioners, physician assistants, a few patients who are still alive, administrators. So I feel like I got a lot of stories to work with. So let's talk about my fellowship project. Okay, so there are two events that happened in the 1970s that I need to talk about in preparation for the founding of Community Medical Alliance. And that is the founding of Boston Center for Independent Living. BCIL was the second Center for Independent Living, or CIL, founded in the country. It was founded in 1974, originally at the Boston University School of Theology. It is now an independent, nonprofit, 501c3 organization. And this is a screenshot that I took of its webpage about a week ago when I was putting my slides together. So it's a very vibrant organization to this day. We also had the founding of something called Urban Medical Group. It was founded in 1977 as an experimental nonprofit interdisciplinary group practice that aimed explicitly to care for poor, chronically ill, older people, including those residing in nursing homes. And the founders of Urban Medical Group were nurse practitioners and physician assistants and primary care doctors who had been very integral to the community health movement in Boston, which was a pretty vibrant movement at the time. And so to avoid competing with neighborhood health centers, they decided to locate their practice in a housing complex for older people at 545 Center Street in Jamaica Plain, neighborhood of Boston, the Forbes building. In this building, 25% of the units are fully subsidized, 50% were partially subsidized, and so this was a housing building where many older people who were poor and low income lived. So they got to work. They did kind of intensive primary care interventions in the home. And they collected data and they published an article in the New England Journal of Medicine, one of the best journals in medicine in the world. In June of 1980, it's called just simply the New England Journal article, and it showed that they had, with their intensive primary care, indeed been able to reduce hospitalizations even for people in nursing homes and including for those people in the Forbes building where their practice was located. So the NEJM article got lots of publicity locally, and this caused the BCIL members to begin thinking, why were they just focused on older people? Couldn't younger people also be part of this intensive primary care effort that Urban Medical Group was undertaking? And so the story might be apocryphal, but it's been told to me so many times, and the numbers actually do kind of tie out, with, including with the date of this Boston Globe article from 1983. And the idea is that one summer night, a bunch of wheelchair users rolled from the BCL offices over to JP, to Jamaican Plains, to the Urban Medical Group offices carrying beer. And they said, we are here to talk. We want to talk about you beginning to provide care to us. And there were two PCPs who were there late that evening. One was Bob Master, the other was Marie Felton, both of whom had founded Urban Medical Group. And they spent late into the night talking and planning what became Community Medical Alliance, based explicitly on principles of independent living. So here we have the three major founders of CMA. To the left, with a shoulder-length dark hair, is Mary Glover, who is a nurse practitioner. To the center, with a long dark hair, is Marie Felton, a primary care doctor. and standing behind her is Bob Master, who is also a primary care physician. He also served in the interesting role under Governor Michael Dukakis as the medical director of the Massachusetts Medicaid program. And so he was pretty kind of into the health policy in the state. A nurse practitioner and office manager are with them in this picture. But they needed to spend a little bit of time figuring out how to make CMA happen. They also needed to figure out how to get paid. And this required approaching Massachusetts Medicaid to get capitated per member per month payments that they would then use to provide this in-home professional care. So Bob went and talked to Bruce Bullen, who was the commissioner of Massachusetts Medicaid at the time and indeed for 10 years. And Bullen was having a problem because he had two really expensive populations that were just draining the coffers for Massachusetts Medicaid. And those were people with severe physical disability and people with late-stage AIDS. Remember, this is before heart. And so Bruce Bullen said, look, I'll pay for capitated care for a demonstration program from 1992 to 1996 if you will explicitly enroll these two populations. And Bob said, you've got a deal. And so years later, this is actually the cover of US News and World Reports from October 5th of 1998. CMA was viewed as the best HMO in the country. And if you open that issue of US News and World Reports, this is the first page, and here you see Bob examining, doing a chest auscultation on his patient in his home. And the first sentence in this article is, quote, Bob Master wants to erase all your bad images of HMOs. And this is Mary Glover caring for Peter Cronus, who worked at the Boston Center for Independent Living, and I was able to interview him and Mary for my project. So Massachusetts Medicaid wasn't going to wait around for US News and World Reports to rate their demonstration program. So in fact, midway through the demonstration program, they hired the National Committee for Quality Assurance, which had been founded in Washington to develop quality metrics for managed care organizations. And June 20th of 1994, they wrote a letter to Dr. Bob Master about their findings from their evaluation of CMA. Quote, CMA is not only unique, but the results you are achieving are so positive they ought to be widely shared. The dedication and commitment of the staff is a significant factor in its success. NCQA urged Master to assess what contributed to retaining such excellent caliber staff, adding that, quote, CMA enjoys loyalty and goodwill among its clients, a significant asset for CMA, which should be protected and nurtured. So before I finish, I just want to briefly say that CMA was not the only program in the country that was trying to figure out how to care for people with severe disability or chronic illness in their homes. The most iconic other program was based on the on-lock intervention that happened in San Francisco starting in 1971. And eventually evolved into something called PACE, a program of all-inclusive care for the elderly, in 1995. On-Lock and then PACE cared specifically for older people. People would continue living in their homes, but they were transported from their homes during the day to adult daycare, and care decisions were made by interdisciplinary teams of professionals, not by patients and their families. So the contrast is that Community Medical Alliance cared for younger people. They supported them in their homes, 24/7, and it was built on principles of independent living, consumer autonomy, empowerment, self-direction, and dignity of risk. So my fellowship project is to review the transcripts and primary source materials and to try to find that secret sauce. What was it that NCQA saw that CMA was doing that attracted the loyalty and goodwill of its members. And so here's one of the gentlemen that I interviewed who had been a CMA member. He was quadriplegic from a spinal cord injury in his early 30s, in his early 20s actually. Were CMA's clinicians so unique that their care model cannot be replicated, Dennis asked me? Or do generalizable lessons for supporting people at home emerge from how CMA clinicians interacted among themselves and from participants? So I always like to end my talks with Independence Day. And so here we are. Thank you for listening to me.
Thank you so much, Lisa. I see that there are a few questions already, but please do feel free to ask any questions that you want. Okay. So the first question, Lisa, is the Willowbrook situation is jarring. My hunch is that terrible treatment still goes unreported. In what ways are news outlets not doing well on covering these issues?
Uncovering these issues, yeah. That's a fraught question, given the New York Times article that just came out last week. Those of you who know, my colleagues and I recently published an article in the New York Times that got picked up by the New York Times. The article was actually published in the October issue this year of the journal Health Affairs, where based on research that we had done, we found that doctors do not particularly treat people with disability very well. And so if you start all the way from the top of doctors not treating people with disability very well, in fact, there were other results from that project that were published, survey results that had nationwide estimates about physicians' feelings about people with disabilities. And in fact, 82% of US doctors think that people with disability have worse quality of care than other people do. And if doctors are somehow in charge of these institutions and they do not respect the lives of people with disability, I think that you have a setup for situations where this is going to happen. But in fact, we have HIPAA provisions. You know, you can't actually, I work at a hospital. Every year we have to take courses about how to protect privacy. You get really punished very badly if you're caught taking a picture with your smartphone in a hospital. And so, just trying to get in there and do the reporting on what is happening in institutions would be really difficult.
Is one of the challenges today in increasing independent living principle-based care that funding is tied to Medicare and Medicaid?
Medicaid is actually a lot better than Medicare. And again, remember that Medicaid is the welfare program that is run by states and the federal government jointly. And in fact, there have been some Medicaid programs that have used their waiver options. This is really technical. This is kind of like in the weeds policy stuff. But they've used their waiver options, in fact, to develop consumer-directed programs for personal assistance services, for example, where it's not an agency who hires the personal assistance worker. It's actually the consumer who makes that hiring decision. And one of the things that I will just reveal here, that I've been a board member on Boston Center for Independent Living since 2005, so I'm not a completely, objective person here, but BCIL, founded again in 1974, was the first CIL, again, in the country to negotiate with our Medicaid program a consumer-directed personal assistance service program where consumers really make the decisions.
And with regard to that, with consumer preferences, what are your thoughts on state models of care that utilize family members as personal care assistants and pay them?
Yeah, it's a really great question. So again, this is really in the weeds. Medicaid has had an alphabet soup of different types of waivers, starting with the 1981 waiver that allowed them to pay more for home-based and community-based services. And over time, they started realizing that family members who were being forced to stop working to care for their relative because their relative was disabled or sick were providing a service and should be paid for that. And so it very much depends on the state and what waiver program for Medicaid the state has chosen to enact. But many states now around the country will pay for certain family members to actually provide that care. And they differ according to which family members they will allow their Medicaid programs to pay. But this is a win-win for everybody because it means that the family member who otherwise would lose income now has some income to be able to support their families. Yeah.
So there are a few questions here that are linked to one another. So the first one is, why did the Community Medical Alliance end? Are there similar programs ongoing now that we can learn from?
Okay, so the Community Medical Alliance demonstration program ended in 1996. It shortly afterwards was absorbed into Neighborhood Health Plan, which was a neighborhood health plan, another HMO, but it was, not the same once it got absorbed into Neighborhood Health Plan. And I just want to say briefly that there were probably, through the 1980s and early 1990s, 20 or 30 different demonstration programs funded by Medicare and other organizations to try to figure out how to crack this nut of caring for people in their homes and communities. And when the demonstration program and funding ended, the program ended. And so it's been very hard to sustain this endeavor. I don't really feel like I have time to go on to the fact that Bob Master went on to try to go to scale. And in the early 2000s, he and a number of other colleagues founded what was called Commonwealth Care Alliance, which tried to kind of cover both Medicare and Medicaid dual eligibles with this type of supportive services. It's still ongoing, but it also has had to ratchet back its kind of IL principles. And so this is hard. This is hard. Yeah. That's why, as I said at the very beginning, we still haven't cracked this nut.
Right.
Yeah.
So let's get to your project now. The listener is asking, what are your early findings? And do you have any ideas about the secret sauce so far?
So I don't have any early findings yet because I thought I was going to have time during the pandemic to start looking at this stuff. I didn't. I ended up being incredibly busy during the pandemic, as probably a lot of you were as well. But I did all the interviews, right? And so I can begin to tell you that the secret sauce was just the unbelievable commitment of these clinicians. I mean, they were available 24/7. Let me just tell you what's actually not a secret, and that is that Bob Master and Marie Felton were married and had children together. And, if one couldn't go when the patient was calling in the middle of the night, the other would go. And so that's why the question that Dennis asked me that I talked about at the very end which was, is this just so unique because the people were so unique, is actually a question to ask. But let me just pause to note that because of the pandemic, there's been a lot of burnout among clinicians. A lot of a feeling among the doctors and nurses that I hang out with at the hospital where I work, that and other hospitals in the city and people that I know around the country, that they're not doing the mission-driven work that they were trained for. And so going back into the field, go back into the homes, visit people in their homes and communities. Could this be a way to reestablish a sense of mission and get them again energized about helping people?
Yeah. There is research that demonstrates that it's also not just for disabled people, but for every other patient, basically, that at-home care is more successful. The next question. So you still have to do analyze your data, that's fine, but you've published books and on the topic previously. So the listener is asking, how are your findings informing medical training?
Findings from this project haven't informed medical training at all yet, because there aren't any findings from this project yet. But finding from my broader work, 25 years looking at healthcare disparities for people with disabilities, it is only now beginning to be picked up. There actually is an increasing sense of urgency out there that there does need to be what they're calling basic competencies in disability in the training of healthcare professionals, and this is interdisciplinary. This is not just for physicians. In fact, there are some professions that I will not name that I think are more medical model than I would like them to be. Really do not understand kind of the social model of having a disability. And so I think that, I will just continue to push on this. And I do think that the stories that will probably come out of this project, stories are what really kind of drives policy, stories and numbers. And I'm hoping that some of the stories will be able to find their way into education of healthcare professionals.
So I'm going to ask a couple of questions together here. So the first part of the question is that we are seeing a national backlash against decades of civil rights improvements, I would say. Have these politics impacted the gains that you have spoken about? And the second part of the question is there a country out there that we should look at to learn and make things better here?
Yeah, that's a great question. Let me just say that I rehearsed my talk for my husband last night. And he said, Lisa, only Americans are going to relate to this talk. And you've got people from other countries in the fellowship. And so it literally is true. And that's why I kind of started by saying that this is very much a national thing. That America was founded on the expectations that it would be individual families, not communities, that would find a way to support their members who became ill or disabled. And so yes, in fact, there are examples around the world of other countries that do this much better. I happen to know a lot about how this is done in the UK because my best friend was born in Birmingham, England, and I just know a lot about that. But even with their conservative government over the last 10 years, the National Health Service has begun to ratchet back, hasn't it? And I think the population around the world is literally aging. And so the impending crisis that I talk about in the United States is very much present in places like Japan, I think Italy also. The Italian population is very much aging. And so I think that, that this is going to be a problem. Let me just say that from my point of view, the most important Supreme Court ruling from the Americans with Disabilities Act was the 1999 Olmstead VLC ruling. That was written by the late Justice Ruth Bader Ginsburg. And in it, she said that under Title II, people with disability have a civil right to live in their homes and communities rather than in institutions if they want to. But she was limited in what she could say in her decision because it was in the context of the Georgia Medicaid program. And the Supreme Court does not have the authority to tell Medicaid programs how to spend their money. And so if Georgia is not going to spend enough money to support all the people who want to live in their homes and communities, they're going to remain in institutions. And so that's what you see happening right now, and that's, was going to be part of Joe Biden's Build Back Better plan. Some of you might remember there was going to be money given for home-based supports because there were 180,000 people, on the waiting lists for Medicaid home-based services. Yeah.
Okay, so where do we go from here? The next question is, what does activism look like in the disability justice movement now? And how has COVID-19 changed broader goals around disability and justice activism?
Those are really great questions. And let me start by admitting very clearly that disability civil rights activism initially was a white happening. It was something that white people led. There are some major exceptions. For example, Section 504 did not get implemented until there was a huge protest. The federal office building in San Francisco, California, was occupied by people in wheelchairs and people who were deaf and hard of hearing and people who were blind. And they stayed there for almost a month. And it was the Black Panthers who brought food in because the federal government had blocked off hot water to the building and food to the building to try to starve people out of the federal office building. And so the thing that I'm seeing that is just so wonderful at Boston Center for Independent Living, which I can talk about now, is we have young people of color who are coming and taking the lead. Our board chair is an Asian woman who graduated from Harvard, has always used a wheelchair, and is just out there advocating. She's seen with Congresswoman Presley talking about the subway system and the buses and not being accessible that we all kind of know something about. And so I think that seeing a more diverse community of people, a younger community of people come into disability civil rights advocacy is happening out there, and that's what's especially fun. And I think that COVID, let me just say, and I hope I'll phrase this in a way that people won't get angry at me for saying, but COVID was a mass disabling event. Long COVID affects maybe 50% of people. We don't really know the numbers yet. We also know that the killing fields for COVID initially were nursing homes and independent, assisted living facilities. That is where people were dying right and left. And I will tell you that it did not go unnoticed among the disability community. The politicians in our country at the beginning of the pandemic would say to the public, don't worry, it's the old people and it's the people in nursing homes that are dying. You're going to be fine. It didn't go unnoticed. We noticed that what that meant was that our lives were not respected. We could die. This would not matter. And so I think that the big problem with COVID is that there are no statistics routinely collected in public health surveillance systems or in hospital administrative systems about disability. There is information collected on race and ethnicity, on gender to some extent, but nothing at all on disability. And so we can't really tell you what the numbers are. All we can tell you is what we are hearing anecdotally in the community.
Thank you, Lisa. Thank you for your presentations and for your perspectives. Thank you.